But the merging of family systems, what happens is that then it becomes, well, there's several things that happen. So you could be vying for control, right? So, it becomes kind of the Lion King kind of scenario, right? Which, at the end, the lion's on top of the thing. So who's vying for the top position? So that can cause a change in strategy or role. And then it also depends upon the wellness and health of how those family systems are merged.
Staten Islander News is here today with Daniel J. Fox. Daniel Fox is a licensed psychologist in Texas, international speaker, and multiple award-winning author. He has been specializing in the treatment and assessment of individuals with personality disorders for over 20 years in the state and federal prison system, universities, and in private practice. His specialty areas include personality disorders, ethics, burnout prevention, and emotional intelligence. He has published several articles in these areas and is the author of The Clinician's Guide to Diagnosis and Treatment of Personality Disorders, the award-winning Antisocial Borderline, the award-winning Narcissistic and Histrionic Workbook Treatment Strategies for Cluster B Personality Disorders, Narcissistic Personality Disorder Toolbox, the Borderline Personality Disorder Workbook, and Complex Borderline Personality Disorder, How Coexisting Conditions Affect Your BPD and How You Can Gain Emotional Balance. Dr. Fox has been teaching and supervising students for over 20 years at various universities across the United States, some of which include the West Virginia University, Texas A&M University, University of Houston, Sam Houston State University, and Florida State University. He's currently a staff psychologist in the federal prison system, an adjunct assistant professor at University of Houston, as well as maintaining a private practice that specializes in the assessment and treatment of individuals with complex psychopathology and personality disorders. So good morning, Dr. Fox. It's good to have you with us.
Thanks for having me. Thanks, I appreciate it.
No problem. So Daniel, one of the main reasons why we wanted to interview you is because there's been a lot of kind of coverage and excuse me, like videos about narcissistic personality disorder and some of the other personality disorders. But most of the time, the videos say they're from the victim side and they say run. And that's their solution. Run away. Don't even try. Just give up and just move on. Right. So I found that one of the things that was different about your practice is that you've actually worked with people who have had these personality disorders and have been able to, whether it's overcome them or live normal lives where they can have, normal interactions, you've actually helped them to kind of come through that darkness of their personality disorder.
Yeah.
So what I wanted to start with was if you can kind of discuss the differences and similarities between antisocial personality disorder, narcissistic personality disorder, and borderline personality disorder.
Okay, sure. So, so there's a huge difference between antisocial personality disorder and borderline personality disorder and narcissistic personality disorder. So as we go on, I'll just refer to ASPD for antisocial personality disorder, NPD is narcissistic personality disorder, borderline personality disorder is BPD. And that just makes it kind of easier. But so for ASPD, actually, if you look at it from a treatment standpoint, not necessarily a diagnostic one, that a treatment standpoint, antisocial personality disorder is a management disorder. Whereas for narcissistic, borderline, and pretty much the other personality disorders as well, those you can look at from a treatment standpoint. And the reason for that is because for antisocial personality, for individuals along that spectrum, it's very hard to bond with them, to get that therapeutic connection, to get them to collaborate. Because what happens is that they have what I call core content. And these are those things, we all have core content. And, some are good, some are bad, some encourage maladaptive patterns, adaptive patterns, so on and so forth. So for individuals with ASPD, we see that they often have core content of power and profit. And what happens is having that core content, it drives these individuals to typically act out or manage that need for power and profit through maladaptive strategies. Like in a therapeutic environment, you want to attach with your client, you want them to feel comfortable so they can open up and you can discuss it. Whereas for your antisocial individuals, those folks are always trying to see the angle. They're always trying to figure out, well, what else is there? What else can I get out of this? Or it's an insincere approach to treatment. It's a letter for a judge. It's to keep a partner in the relationship sometimes, so on and so forth. So there's a whole host of reasons. But the genuine reason tends not to be to manage or work on the maladaptive patterns that are manifested from core content. Now, if we look at narcissistic personality disorder, borderline personality disorder, we see that these individuals are more open to treatment. Individuals with narcissistic personality disorder, they're not too keen on going into therapy. I mean, narcissistic personality disorder is traditionally treatment rejecting. So that means that they're not coming to treatment, they're not open to the idea of treatment. However, and I think we see more of this, particularly in the last probably 8 to 10 years, as there's more research coming out about treatment management, as well as the numbers of individuals with narcissistic personality disorder that are coming into treatment or that have traits. There's a big difference between the two. But when we have individuals that are coming in for treatment with NPD, typically their core content tends to be fear, shame, doubt, guilt, or inferiority. So those are protected by a lot of kind of perceptions of I have to be great, I have to be special, I have to always be treated as though I'm unique and special. Everything I say has to be valued, and I have to be praised on a regular basis. Otherwise, I act out, and whether it's aggressive or passive aggressive tactics, then I have to engage in those things in order to get my needs met so I can protect my core content. In therapy, once they come into therapy, typically it's following what's called a narcissistic wound. A narcissistic wound is typically something happened that really hit their core content. Could be that, their high status partner was like, I'm out of here, you're useless. Could be medical problems, could be impotence, heart problems, stroke. Their functioning has significantly decreased. So then what happens is that it manifests as depression and anxiety. That sometimes can drive them in. So it's that narcissistic wound we typically see them come into treatment with. Then in treatment, that it's a very delicate balance. And I often pair it when I'm working with my doctoral students or I'm training other mental health providers. I like to look at individuals with NPD a lot like kittens. And when you bring a kitten home, what's the first thing that kitten does? It shoots under the couch, right? Because it's afraid. And, maybe you put out little tender victuals or little, snacks, and you slowly, let the kitten come out and stuff. It's the same thing. For somebody with NPD, you have to be very careful and very gentle. And they have to perceive you as safe, because what they're afraid you're going to find out, what they're afraid you're going to uncover is fear, shame, doubt, and inferiority and shame. So it's a very slow process. For BPD, these individuals typically have core content of abandonment, rejection sensitivity, and emptiness. They are treatment seeking. Out of all 10 personality disorders, there's only 2 that are treatment seeking. That's histrionic personality disorder and borderline personality disorder. Folks with borderline personality disorder, Typically there is a reluctance to engage, but a desire to change. So we have to tap into that. However, there is a reluctance of a push-pull kind of relationship. So as you get closer, they back off because can you really be trusted? So it's a lot of boundary testing. It's a lot of attachment testing, confirmation of the relationship, verification, so on and so forth. So in working with these individuals, you're often trying to manage a lot of those maladaptive patterns, also encouraging them that it's a safe space and trying to teach them adaptive strategies. So it's juggling sometimes. But because they're treatment seeking, in my opinion, it tends to be, generally stated, easier than working with someone with NPD until you can get underneath what I call the narcissistic, the veneer of perfectionism. Once you get under that, then things really change. You start to bond and really connect. And it's amazing, absolutely amazing when you can get underneath that veneer of perfectionism and start doing the work. These people become very adaptive, very goal-oriented, very effective through getting their needs met in an adaptive way. Long answer.
So basically, would you say that a person with antisocial personality disorder, they're not treatment seeking? Are they more difficult to treat than the other two if they do try to find treatment?
You typically are managing the disorder. So you're not really treating per se. So when I say treatment, it's getting into that core content, it's working through it, because a lot of these individuals are reluctant to be like, look, it's about lessening your power and profit so that other people can benefit from your interaction. So other people can get a sense of closeness to you. There's so much resistance to that, because if you tell someone who's along the antisocial spectrum, well, we're going to work on lessening your power and profit, you're going to get an expletive probably. And yeah, they're just not driven. And Tony Soprano, I think, is a great example. I think Sopranos is a great example of managing somebody. Now, he is sociopath. A lot of people think he falls into psychopathy, but he doesn't. He actually meets criteria for sociopathy. But is that you see this secondary desire to attend treatment for him to manage panic attacks, and manage is the critical term. They may come in with depression, anxiety, panic. You're not going to go into childhood histories, childhood issues. What you're going to do, or most effective thing to do, is manage the presenting problem. It's very different than somebody with narcissistic personality disorder, because or even BPD, because the depression, anxiety, panic tends to be driven by those core content areas, whereas they may be driven for those with antisocial. But if you try to get to core content, typically the defense mechanism of many individuals along the antisocial spectrum, depending on the severity and so forth, is violence, manipulation, aggression of varying degrees, verbal aggression, physical aggression. So there becomes a threat to the provider.
Oh, okay. So in therapy, those things that they tend to do to their significant other or their children or their partners or whatever comes out towards the therapist themselves.
Okay. Yeah, okay. because you're going too deep. So now they have to protect themselves, and you see it. I mean, in working in the prison system, it's interesting because I've had people, and more often than not men, but who they would come across, they respected me to varying degrees, but they would come across and say, doc, you're going into an area you don't want to go. I'm like, okay. And I respect everybody's space, you know what I mean? So and it's usually just me and that person in a small room. So I'm usually pretty respectful. But individuals with narcissistic personality disorder or borderline personality disorder, they tend not to do that. They don't kind of, do the lean in, like, doc, you better back off. They don't do that. Typically, they engage in more self-attack And in some cases, they may attack more for narcissists than for individuals with BPD. But your antisocial person absolutely gets a lot of satisfaction out of, lack of a better way to phrase it, thumping their therapist. So
okay. And when you said, like, a lot of times the narcissistic personality disorder, people who suffer with that would not come in on their own for therapy, do you find that they are more often like dragged there by their significant other, or by like, well, I'm going to leave you unless you do this, or whatever it is? Do you find that that's more the case with them?
Oh, sure. And I think that's really common. Usually, because they're treatment rejecting, there has to be what's called an external object. Could be a partner, could be they have a lucrative job, and they've acted out in the office, or they threatened a staff member or another coworker, and that person was like, okay, well, you're going to go to EAP, an employee assistance program, and you're going to go. So in order for them to keep their high status, valued job, partner, whatever it is, then they come into treatment. So in many ways, they're like a mandated client, which is, the court has mandated that they come to treatment. But when you start, what you do is, it's a very slow process. And first thing you have to do is, you can't be traditional, which is, well, Steve, you're here because you threatened, Mary in the office. I mean, right. That's really not going to do it. It has to be more of, have them explain it, have them get a sense of power and control over the session, but not too much where they're demonstrative. So it's really a balance. It's dancing. I can't dance, but boy, can I do therapy,
Right. So, because I know, like, what we're going to get to in a little bit, of some of the dysfunctional portions of the dysfunctional behaviors of the narcissistic personality disorder is kind of like, how do they keep a job? How do they get the job in the first place? How do they stay there past 6 months with all of these behaviors? Which, what it seems like is that a lot of narcissists, like, and I've known narcissistic people in my life who, there's that expression, the street angel and the house devil, where they are horrible to their family members, their kids, their husband, whoever they live with, but they're able to kind of like put it inside when they go to work, where they go to their job, or whatever, like where they would really get in trouble for some of the things that they do.
That they say and do, for sure. And I think the best way to answer that question is to recognize that, so all disorders, whether it's NPD, BPD, depression, anxiety, schizophrenia, everything is on a dimension. So they're dimensional. So you could have absent, mild, moderate, severe, or extreme. Now, if we're just going to talk about the two ends, so mild narcissism is somebody who's kind of, they're pretty stuck on themselves. They may not listen a lot. They turn conversations off into themselves for their own benefit. And then, so those folks can typically manage and work within environments. Actually, even with moderate, and most individuals, all disorders fall on a normal curve. So the majority of individuals have moderate narcissism and moderate narcissistic personality disorder. But NPD and BPD actually tend to be misconstrued as extremes only because of examples in movies or books or, whatever it may be. So we conceptualize only extreme, and that's a problem, because mental health providers who have, seen the same movies, read, the same literature, whatever it may be, that's their conceptualization. So they miss the meaty part of the curve, and we can't do that. So anyway, so somebody who has extreme NPD or even severe, they're going to have a lot of trouble keeping a job. You're going to see a lot of serial employment, one job to the next, a lot of unemployment, office acting out, coworker threats, in the example we just talked about, things like that. So you see that these folks in the severe or extreme, they have trouble functioning across contexts, and that's critical. So when we talk about, the angel in the house or the devil, wait, I think I got it backwards. Wait, where are they an angel? Where are they?
The street angel and the house devil.
Yeah. So so when they're at the house, they're just a nightmare, right? But when they're out of the house, they respect laws and rules and stuff. But what that actually tells us, that person has some adaptive strategies, because if they didn't and they were severe or extreme, then you would act the same across contexts, which is whether I'm at the Cheesecake Factory, I'm at work, or it's you and me, in our bedroom together with a spouse, and so you don't see that. So when we see that you can have that differentiation, that tells me as a mental health provider, oh, okay, all right, what are those adaptive strategies that helps you keep in check at work, but at home, you're flying off the handle. We have to generalize the adaptive strategies into the environment where you're more maladaptive and get a greater sense. But typically severe and extreme aren't able to do that because it's such a strong drive to engage in these narcissistic patterns that are so destructive.
Right. And is this like is the personality disorder, does it tend to be like an evolutionary thing? Like someone starts out moderate and then they don't get help and they keep going into the same maladaptive behaviors and then they get worse?
Okay, so do you mean that they get worse? Do they get worse as they age, or do you mean do these behaviors, are they genetic? I'm not which.
No, I mean like as they age, do
Okay.
they go from moderate to severe or extreme in some cases?
So this is and you're really, that's a great question, because you're tapping into one of the great challenges of doing research with individuals with NPD, which is that they don't do research because they don't want to be evaluated, because they don't want people to find out that you have fear, guilt, shame, doubt, and inferiority. So if they participate in treatment, it's typically in a singular fashion. Could be because the research is paying $50 a pop, to fill out a questionnaire or whatever. So they don't tend to participate in longitudinal studies, which is like BPD. What we see, and I would actually probably, I would hypothesize that it's very similar to BPD. So what happens is we used to believe that as individuals got older, that they aged out of BPD. But that isn't true. Actually, there's a lot of research in the last like 5-7 years. It's very, very cool, because what it shows is that really these individuals aren't aging out of BPD. It's a change in behavior. It's a change in the maladaptive behaviors. Let me give you an example. So you have individuals that had BPD in their 20s and their 40s and their 60s. Now they're in nursing homes. And in the nursing home, we see them acting out and engaging in those same maladaptive behaviors in order to manage their core content. You don't age out of core content if you don't build insight and adaptive strategies. Core content is in control and stays in control, whether you're in your 30s, 40s, 60s, nursing home, whatever that may be. So we see that these folks, if promiscuity, for example, at 20, the individual engaged in promiscuity, we'll see even in the nursing home that the individual engages in promiscuity. If it is throwing objects, we'll see also when they get into nursing home, they're throwing objects. But as opposed to the degree or the expression of violent behaviors, it's harder to be as violent and aggressive at 75 that you're not flipping tables. Most people aren't flipping tables at 75 that they were at 25. So we see an adjustment, but that was misconstrued to say, oh, well, they're growing out of it. I mean, they're aging out. So that isn't true. So I would guess that it would be the same for those with narcissistic personality disorder. Is it those needs that aren't met, that there's no insight, it's not managed well? They continue, just the maladaptive strategies change to fit what the individual is able to do. And if they're along the narcissistic spectrum, and as we get older, we know we start to have more chronic issues, medical issues, things like that, then you get an immense exacerbation of maladaptive strategies, which is, more argumentative. They may, more passive aggressive behaviors. And so, I mean, it just adds to it. It amplifies as the individual is ill. And even chronic pain, I did a video with another psychologist here in Houston, and Dr. Liz Ross, and her area is chronic pain. We talked about narcissism and chronic pain, and she was absolutely, it's narcissism component added to chronic pain. You have to change your approach. You have to adjust, because this is not your, and I'm using air quotes here, your average NPD or client with NPD, because the chronic pain amps everything, turns everything up to 11.
Right.
Spinal tap.
So, yeah, and like I've known one of the videos that you had about the narcissistic female was clearly was about the overt narcissistic female, and all of the narcissistic females that I know were nothing like that, because they're not the high heels type, and they weren't pretty, like they weren't beautiful, so it wasn't like that just kind of didn't happen for them, but they're still definitely narcissists. I mean, I knew one person who, when their husband decided that they were kind of considering a divorce, they tried to run him over twice. They tried to smash him in the head with a what do you call those, flashlight, and
that's more antisocial behaviors or traits. So so that changes the narcissistic perspective. But I'm sorry to interrupt. Go ahead.
No, sure. And what ended up happening is that because she was a female, she did get arrested, but the case was dismissed because it was like, oh, she's just a woman, it's okay. So so sometimes I feel like there's a lot of covert narcissists, and that's what the books that I had read about toxic personalities and emotionally immature parents and stuff may have, like, they may have been on the narcissistic spectrum, but they never got help for it, or they never like acknowledged it, and just kind of lived in society kind of under the radar of, because the only person that they were abusing was their husband. And if they had kids, it would have been their kids. But in the cases I'm thinking of, they didn't have kids. So it just kind of becomes like, how do you help like covert narcissists to recognize that they have this thing where it's kind of hidden? It's kind of like, it's kind of hard to put your finger on unless you really have like a list of all the behaviors that you're looking for, and you're like, you do that, and like, so I'm just curious as to, how do you see a lot of covert narcissists in your practice also, who like nobody really knows that this is what they are?
Yeah, no, absolutely. And that's a great example. And I think that it really illustrates the challenge. Most narcissists are not violent, whether they're male or female. So once you add components of violence, then you're adding in antisocial traits, typically, particularly if it's prolonged violent response. Like if you get frustrated and you act out impulsively and try to run your husband over or your partner over because they suggested, ending the relationship. If that's a one-off, like, instant, it's a terrible thing to do. But if it's a one-off, I mean, I wouldn't attribute it necessarily to the narcissism. I would attribute it more to that person gets angered, and you're certainly tapping into core content. But I think that they're acting out in an impulsive way. But when you have people that are along the narcissistic spectrum and they have an issue of violence, like the best example of an individual that has sort of NPD and ASPD, whether they have both disorders or a combination of traits, that typically you'll get the individual with the personality disorders will often say, well, you'll be dead before you leave me. It's that ownership statement, right? Which drives that person to run them over, stab them, stuff like that. But that's typically not just narcissism. Now you're adding in antisocial traits, which means whenever there are antisocial traits present, you have to move from treatment to management. That becomes the problem. People start to believe that, oh, well, we still have to treat this as narcissism. Wrong. Once there's antisocial traits, you have to switch to a management approach. If you don't, you're just smacking your head against the wall, and you're not going to get any real efficacy. But in talking about sort of overt and covert, the reason why it's called covert is because it's outside of the expectation. Like what we expect is a grandiose type, right? Which is overt. They're over the top, they're showy, high heels, like you mentioned, jewelry, living way beyond their means, typically, so on and so forth. For your covert is also called vulnerable. And it's really about the expression. So the grandiose classic type of narcissist, I think we're all familiar with that, right? Showy, egocentric, stuff like that. But for your covert, for your vulnerable, these folks present as very much a woe is me, and a good way to encapsulate it and really have a sense is that what they're experiencing is so bad, so painful, and they are so broken, no one else can understand or relate. And that's the narcissistic component. I suffer so much that you, whether it's my friend, my parent, my therapist, can't understand and relate. That is a narcissistic statement. And typically then in treatment, and a lot of mental health providers that aren't really aware of what they're working with because they only conceptualize narcissism to be the overt grandiose type, then their heart really goes out to them. And so they're giving them all these strategies. And then the covert narcissist client is like, no, that's not going to work. Well, how about deep breathing? No, that's not going to work. How about, maybe, doing mindfulness? No, that's stupid. I'm not doing that. So those are all narcissistic rebuffing approaches, whether they're overt or covert. So it's really about the vulnerable. They show this immense vulnerability. And so that's how it's hidden, because it's outside of what we expect it to be. But just as challenging. And most therapists will align, regretfully, with the covert narcissistic individual because they don't know that they're aligning with the covert narcissistic individual, because most therapists are empathic and they're like, oh my God, he or she's really struggling and I really want to help them. And it pulls on your heartstrings and all this other stuff. And that's all very nice. But the reality is that if you're in that narcissistic vein, you have to be able to recognize it so you can treat it. If you can't identify it, you can't treat it.
Right. And I know, like, a lot of times the same as with the overt narcissist is the denial, the gaslighting, the making up stories, the perpetual victimization. Like, I'm the victim all the time. And then they're going to bring that to the therapist. And I guess if the therapist is not also interviewing the other people in that person's life, they're going to just take that person's words at face value, like you would with someone who doesn't have that kind of personality disorder.
Absolutely. And I think that a lot of individuals, with NPD, covert or overt, they don't like third party input, which is partner, or family member, whatever. They typically are against that because it's harder to manage the narrative and your image if there's additional data coming in. So they typically don't allow that, or they won't give consent for those other people to give up some information or fill out, worksheets or background.
Even though it would actually help them more to do that, because then that would be acknowledging what's actually wrong.
Well, and it would help them down the road. But the issue is, remember, they're always protecting fear, shame, doubt, guilt, and inferiority. So if you get data, you're going to realize, you, the therapist, are going to realize, or you're going to uncover that I'm really weak and can't really function. And then you're going to kick me out. And just like that kitten, then you're going to squash me because I'm easy to be squashed because I'm a kitten, right? I'm not a lion. You can't squash a lion as easy as you can a kitten, and we shouldn't be squashing anything. But you get my point. Yeah.
Right, and it would seem like that's kind of their fear. They have that abandonment fear as well, like the NPD and BPD. That's something that they kind of share, where they think that once the therapist uncovers who I really am, they're going to not want to work with me anymore.
Then you'll reject me and push me out, and that can be some overlapping traits. So there can be some overlapping traits between NPD and BPD. Yeah.
And so what I wanted to talk about next was you had a video on your channel about the family dynamics with, I believe you were talking about narcissistic personality disorder, where parental dynamics and, you know, the dynamics between the husband and wife and the kids, and how there's like the scapegoat, the golden child, the lost child, the hero. If you can go over kind of that a little bit. How they manifest, how they can be combined. Like I know I've read that sometimes in some situations, the usually not the golden child because they're like the praised always, so they're usually just the golden child. But sometimes the scapegoat will also be the lost child in some situations. Sometimes they'll be the hero and stuff like that. So if you can kind of talk a little bit about those kinds of family dynamics.
Yeah, sure. And I think, you know, what happens is, and we all do this to varying degrees, is that we all choose different roles within our family system so that we can function. I mean, we're beings that are built on survival, right? Like rabbits, turtles, lions, kittens, whatever it is. And part of that is, so we have to pick a role that helps us adapt or manage or live through what we were born into. And in this example, we're talking about the family system. So within the family system, what you find if there's a narcissistic parent or parents, typically you don't have both parents being narcissists because they would just destroy each other unless you have one overt and one covert. But we can talk about more about that if you want. But so in that case, typically you'll find a golden child, and the golden child is the one that is most like the narcissistic parent. And that's the one that can do no wrong, that even the smallest gesture is the biggest gesture in the whole wide world and all of that. And let's say that there's other children in the family system. Could be one, could be two, three, whatever. So typically there's only one golden child. There's not that much love and compassion. And actually, compassion is a poor word choice. But I would say that there isn't that much love or attention to go around. So you're not going to spread it around to the other kids and work on, you know, balancing egos and kids, you know, sense of self. What you're going to do is you're going to say, well, Jimmy is perfect. You know, Sally's broken and busted.
Yeah. So you were saying
we were talking about family systems and
right, and about how with the golden child, there's usually not enough of love or, I guess, love bombing to go around from the narcissistic parent.
Well, and it's not even love bombing. It's just, you know, love in the form of like attention and things of that nature. So then the other kids are kind of left with the scraps, right? So the golden child gets the pie, and then the other kids are left with the scraps. Well, the kids have to adapt to that scrap-based environment, which is, so do you become the peacekeeper? So which is, you know, I don't want anybody to argue. I want everybody to be okay. And that's a pretty strong codependency sort of early factor, you know. And there can also be like scapegoating, which is, you know, it's all my fault, you know, I'll take the hit. The hero is I'll always throw myself in front of the train. So these different roles that the individual picks, it's in order for them to survive and live through the family environment. And it's not always with narcissistic parents. I mean, it can be BPD, APD, or it could be no PD at all. It could be just a really, lack of a better word, dysfunctional family environment. So the individual has to survive. And so it's adaptive while they're in that family environment. However, once you get older, you're still using that strategy. And we all learn patterns, and we operate on patterns that we learned in our family of origin or in our developmental environment. So then when we hit our, you know, late teens, 20s, we start to get in more serious relationships. We're still using those old patterns. But what happens is they're very maladaptive. And so now you end up with intense codependency. You end up with peacekeepers, heroes, scapegoaters that are in these relationships, and they end up picking partners. And this isn't about fault. This is just, we all have attraction to what we understand. So we end up picking partners that fit that dynamic. And when I work with clients on this, and we work on the sense of attraction and partners and stuff, then we're getting into attachment. What are our early attachment patterns? And the best way to look at that is to look at Christmas morning, right? Any gift giving morning, right? You come down, there's 3 packages there. The first package looks real pretty, looks real nice. You unpack it. It's a Cabbage Patch doll, right? You're like, oh, I love Cabbage Patch doll. It's what I always wanted. It's what I knew I wanted. It just fits perfect. I love it. Second package, right? Looks a little different, but you undo it and you're like, oh, this is going to be great. It's going to be so different. It's not going to be a Cabbage Patch. And what is it? Cabbage Patch. And you're like, oh, well, 2 Cabbage Patches. All right, you know what? I can kind of understand that. Then you go to the third, and the third package, it looks different. It kind of has a different feel to it. But you unpack it, and what's in there?
Cabbage Patch doll.
Oh, Cabbage Patch doll. Yeah, there you go. Yeah, right. And then you're like, what is going on here? Why am I always getting Cabbage Patch dolls? And that's what you hear from a lot of clients who are utilizing old patterns and roles that they learned, and they're picking partners that fall into that. It's hard to change your attraction and attachment. Not impossible, but it takes work, it takes insight, and it takes unlearning the maladaptive roles and strategies to learning adaptive strategies. And it's a lot like working with a narcissist. And I'm not saying that those individuals that occupy those roles are narcissists. I'm just saying that the process is similar. It's easier, a lot easier, because there isn't that veneer of perfectionism you have to get under with somebody with NPD. But it's going back, revisiting that attraction, revisiting that attachment, and redoing it. And it is amazing. Once you can unlearn and relearn adaptive strategy, it is absolutely amazing. It's one of the best things about my job, is that helping people go from maladaptive approaches to adaptive approaches and enhance their level of success. That's the most amazing thing, whether it's a personality disorder or not.
Right. And I know, like in some family situations with the scapegoats and stuff, a lot of times that's kind of also determined by the narcissistic parent. It's like, well, this person, I'm going to blame them for everything. So I'm going to praise the golden child for everything, and the scapegoat, everything is their fault. So
Sure.
whether they do and then they do tend to internalize that. And like you said, bring it to their next partner where, oh, everything is my fault. This whole same dynamic that they learned growing up, they just kind of bring that to any new relationship and kind of have like codependency and all of those kinds of things. And so what usually happens, do you find something different that happens when there's parents who divorce and remarry and then bring in new kids? Do you find that it's common that the roles will change?
So I do want to mention, yeah, and that's a great question. So when you merge family systems, but so it's typically not conscious. Like the parent isn't thinking, okay, well, this is the golden child, that one's going to be the scapegoat. So they, it's the individual who chooses their adaptive strategy or their strategy to kind of live through that environment. It's not conscious. And one of actually the universal criteria across all personality disorders is impaired insight. Because if they were aware that if I do this, well, I'll lose you, I'll lose my job, I'll lose my status, I'll lose this, then believe it or not, they would significantly decrease the probability of doing it. But because they lack that insight and awareness, they keep engaging in it, even though it's Cabbage Patch doll every time. You keep engaging in it because you're like, well, I mean, eventually, I guess it'll be different. Oh, it's really not. But the merging of family systems, what happens is that then it becomes, well, there's several things that happen. So you could be vying for control, right? So, it becomes kind of the Lion King kind of scenario, right? Which, at the end, the lion's on top of the thing. So who's vying for the top position? So that can cause a change in strategy or role. And then it also depends upon the wellness and health of how those family systems are merged. So is it family therapy to pull everybody together? That would be the best ideal, because you have to look at the family system, what functions, what doesn't in each system, and then merge it together so everybody's on equal planes. Most people don't do that. Instead, they have a Brady Bunch conceptualization, right? I got 3 daughters, you got 3 sons, they're going to merge together, and everybody's going to somehow figure out how to get along. And if something does happen, it's only for about 40 minutes, and then we're fine at the end. So that, and that's really the conceptualization. But the reality is that you can open a lot of wounds, you can cause a lot of confusion, particularly if you have parental alienation on board. And parental alienation is, right, that you demonize the other parent. And I don't mean the other parent of the merging system. I mean the one that
the
is
divorced
outside.
one.
Yeah.
Yes.
And then so you make that one the demon. So that adds more confusion, because now you have someone who's trying to understand the separation of their primary caregivers and their family system. And it's so confusing. So an adaptive strategy is to come together, recognize everybody's roles, whether they're adaptive, maladaptive, whatever they are, and then work together to merge them in a healthy way. And that can be, so, for example, like a hero, for example, somebody who's using the hero role, that individual, you be like, okay, so we want you to engage in this. So when you see something, I want you to encourage others to help resolve it. And that includes me as the parent. It includes the new, other primary caregiver, include us in it. So we're all helping each other. And it becomes very much like a community. That family can become a community with superordinate goals. Superordinate goals are those larger goals we all work towards. So now if we're all working towards equal and balanced roles, as hard as that is, and it's challenging, we find that there's more working together. There's more openness. There's less fighting. There's less, passive aggressive behavior, so on and so forth. And it decreases the probability of those within that family system of developing narcissistic, borderline, or other personality disorder maladaptive coping strategies. Yeah, I do have just about five more minutes. I do have a client after this. I apologize.
Sure, it's no problem. So, one of the things that that your workbook talks about is that there are effective treatment options for these conditions. And do you find that a professional assistant, such as a therapist, a psychotherapist, is like a necessity for like somebody who's trying to recover from narcissistic personality disorder or borderline personality disorder?
Yeah. So I would say that I think the degree of intervention typically matches the severity of the disorder or disorders that are present. So I would say for individuals that are extreme or severe, that they're showing severe extreme personality disorder pathology, for example, so those people are probably going to need a greater degree of intervention. So you're going to have a higher likelihood of benefit from inpatient or intensive outpatient. Moderate, it depends upon the flow and which adaptive strategies they can utilize. So for moderate, I think that if they have some adaptive strategies, if they have a degree of insight, then I think workbooks can be helpful. Online courses can be helpful. There's a lot of sort of self-help things that the individual can benefit from. And if you're finding struggles with that, because, impaired insight is part of it, then you may need a mental health provider to do that. I think if you have mild, like a few traits, of BPD, like maybe you have some abandonment fears, but you recognize it, and maybe you tend to test your partner a little too much. There are like workbooks and things that you can utilize, but if you have the resources, a mental health provider might be able to speed up or assist in that process. So that would be good. So I think it really does depend upon the severity of the maladaptive patterns that are present, what skills, adaptive skills, the individual may already have that they're utilizing.
Okay. And then, so what you were saying about narcissistic personality disorder and people not being able to recognize it, do you find that when they do start to recognize it, then they try to get help?
When they it's interesting. So I would say probably in the last 8 years, I've had more people contact me and say, I think I might be narcissistic, or, you know, the individual, typically narcissists don't come into treatment, but with greater awareness. And, you know, I think that the whole point, you know, of my YouTube channel is to have the information out there that is research-based or my clinical experience-based, not my opinions, you know, even though my opinions tend to also match the research and, you know, so on and so forth. But it's not just out there saying, oh, you know, I'm not demonizing everybody with a disorder. Instead, it's about, you know, here's what's here and here's how to work on it. So I think that there are options for individuals, you know, who do see it. There are a greater preponderance of resources for individuals who see that about getting into treatment and so on and so forth. So I think, again, people are more open to the idea, hey, this might be the reason why I'm always getting Cabbage Patch dolls. Huh. And then you might want to start at a low cost or more manageable option like a workbook. And then if you're not getting a lot out of that, then you know what? Hey, maybe I'll go, you know, to group therapy or a therapist or whatever it may be. So yeah, I think more people are seeking treatment, yeah, for narcissism,
fantastic.
which you didn't see in the past.
No, that's actually really great. So is there anything else that you would like to add for our conversation today?
No, I mean, I think it's really great that we're talking about, you know, narcissistic personality disorder, but we're talking about it in a way that doesn't sort of demonize or even, you know, scapegoat the narcissist. And I think that, you know, that's one of the issues, is that we've demonized this disorder so much that people that have these traits are afraid to seek treatment. They're like, well, no therapist is going to take me. Well, that's just not true. I mean, you know, I've worked with clients for 20 plus years, you know, that have NPD that have come to me and say, oh my God, you know, I think that, and so there are people out there who can work with you, who can help you manage those narcissistic tendencies and move from maladaptive to adaptive strategies. So, and I think it's podcasts or it's interviews like this that help promote genuine knowledge, research-based information being put out to other folks. So they're like, oh, this is something I can deal with and manage and get control of.
Right. Oh, awesome. And I'm also going to share a link with you to a movie review that we just recently did, which is kind of related to this. I don't know if you probably haven't seen it yet because it comes out in theaters next week. It's called Brave the Dark. And the guy who's the main character, he uses your one of your techniques that I saw it this morning in your workbook. He says to himself over and over again, "This too shall pass," to the point where
mantra, yeah.
Exactly. Yeah. So I'm going to send that over to you. And it was really great speaking with you. And I really appreciate the work that you're doing. And actually, I didn't even know that you were in the prison system. I had just seen your workbooks and all of the help that you do on the YouTube channel and stuff. So that's really great that you help those individuals that are, you know, they have gotten to that point of where it's affected their lives in a major way.
Yeah, 21 years in prison. I mean, I've retired from there, but yeah, no, it was great. It was really a great experience. I'm so thankful to the Bureau of Prisons for that experience. It was great. Thank you. And this was great. Thank you for reaching out. This was great.
Thank you so much. It was really a good conversation. I think that our audience and your audience will get a lot out of it.
Thank you. I appreciate it. And I fully agree. If there's anything else you need, just let me know. I'm happy to help.
Thank you so much. Have a great day.
Thanks. You too.
All right,
bye-bye.